Welcome to the Iowa Geriatric Education Center Geriatric Lecture Series. I'm Stacy Salisbury, and I'm going to talk to you today about fall-safe environments in long-term care settings. My disclosure statement, I have no financial interests or relationships with any manufacturers of products or providers of services that I might be discussing today in my presentation. And I'm not going to discuss any particular pharmaceuticals or medical procedures or devices either. I also have a disclaimer statement. And that's when we're talking about falls in long-term care settings. We haven't actually had very many clinical trials or controlled studies that have tested specific fall prevention interventions, which means this presentation is based largely upon best practice recommendations, as well as regulatory advice from the Centers for Medicare and Medicaid Services. So, although they have nothing to do with this presentation, if you're thinking about using anything that we might talk about today in your particular nursing facility, just use caution when you're implementing anything with specific individuals. So the objectives for today's talk, we're going to discuss fall-related terms in long-term care settings kind of from a regulatory perspective and kind of how that fits into how we need to think about falls within this environment. I'm going to describe a model to identify and evaluate fall-related risks and hazards in long-term care setting, illustrate action steps to reduce fall risk among various resident populations in long-term care, and at the end we'll have kind of an extemporaneous proposal of strategies to foster positive staff attitudes towards fall-safe environments, since I didn't get that slide done. So we'll see what we have to say at the end of this discussion. So kind of objective one, discussing fall-related terms in long-term care settings. And I'm going to kind of focus on the idea of accidents, hazards, risks, falls, as well as how we talk about them within the minimum data set. So CMS guidance for surveyors, the state operations manual for long-term care settings. It's, they have a lot of good advice kind of about how to think about falls or a variety of topics in long-term care facilities. But if you're looking for a section specifically on fall prevention, it's pretty hard to find. You actually have to stumble upon it. Falls are listed under the idea of accidents. This is the tag F323, in which states that a facility must ensure that the resident environment remains as free from accident hazards as possible, and that each resident receives adequate supervision and assistance devices to prevent accidents. So, key definitions. The ideas again, accidents, hazards, and risks. I'm going to start with the idea of accidents. CMS identifies two specific kinds of accidents. There's the avoidable accident, and then there's the unavoidable accident. So an accident is any unexpected or unintentional incident which may result in injury or illness to a resident. This doesn't include any adverse outcomes from treatment or care provided in accordance to current standards of practice. So if you're doing kind of what the literature says you should be doing about preventing falls, and someone falls, this may not be of any concern. An avoidable accident, though, is a failure on the part of the facility to identify, assess, or prevent an accident, a hazard, or a risk. This includes the failure to provide adequate supervision, or if care is not provided according to current standards of practice, or if care is provided that is inconsistent with the resident needs, goals, or the plan of care. In contrast, an unavoidable accident happens when a facility made adequate effort to identify fall hazards and risks in their environment and implemented fall prevention strategies that meet those current standards of care, but the accident happened anyway. So when you're thinking about kind of the unavoidable versus avoidable accidents. You know, when there's a big snowstorm and there's ice everywhere, you know, you can't really stop Mother Nature from happening. And so, you know, that is one kind of accident. In contrast, you know, when a floor is wet, you can warn people about the wet floor. You can make sure that residents are kind of guided around the wet floor. You can make sure that the whole floor isn't wet at one time. So these are avoidable accidents. So it's, you know, kind of, you know, think about, is it something that you could have actually prevented from happening versus is it not? So within that definition of accidents, we had the idea of hazards. Hazards are elements of the resident environment that have the potential to cause injury or illness. So the resident environment includes the physical environment to which the resident has access. We're talking about resident rooms, common use areas, facility grounds. Those are the places that need to, you know, kind of be fall-proofed for the residents. Offices, backs, you know, storage spaces, things like this. While it's really good to have fall-safe environments for everyone, including your staff, you know, the focus of these of the CMS is, you know, the physical environment that the resident moves through. There's also the idea within the concept of hazards is that these are hazards over which the facility has control. Environmental hazards where reasonable efforts by the facility could influence risk to residents for causing injury or illness. You need to be free of accident hazards as possible. Going back to kind of my earlier idea of the ice storm. The ice certainly would be a hazard. And so what can you do about that? You know, you can make sure that that the ice is removed as quickly as possible, that there's some type of, you know, non-stick or slip surface put down, some sand or something. You know, that residents are, you know, not going outside during conditions like this, or if they are, that they have a guide. This is kind of my, I think this is a really good slide of instead of where's Waldo, how could Waldo slip? And I'll just give you a second or two to kind of look over this slide for accident hazards that are kind of waiting to happen. Kind of as soon as I saw this picture, the floor mats kind of jumped out at me. Number one, they're not secured to the floor in any way. In addition, there are these upturned edges, which, you know, while our gentleman in the wheelchair, you know, isn't likely to really trip over this spot, someone who's walking could certainly trip over this area. So there's also this kind of small unknown object that's almost the same color as the floor lying there. It's hard to see. It's definitely something that a person could stumble upon. Certainly shouldn't be there. If you look around, there's the glare that's kind of present in most nursing facilities that have the tile floors. And, you know, just figuring out ways to enhance the lighting so that the glare isn't hitting right there, which makes it hard to know if a floor is really wet or dry. In addition, over in the sitting area, we've got these really lightweight tables. They can move easily if you bump into them. People getting up, getting down, kind of this whole area. A lot of furniture that could easily skid out of place and cause a fall for someone. If you kind of look around the entire space, there are very few handrails in the public area. And the ones that are there are either covered up by furniture or are kind of blended in with the environmental clutter. So anyone who's actually walking doesn't really have a good place to kind of grip a hold in this really big space. So we've also got what appears to be an unattended wheelchair, as well as equipment in the walking paths. You know, pretty much hallways are not a place to store equipment, and this just, you know, really gets in the way and would make it very easy for someone to trip. In addition, we've got a person that's all off by themselves. We've got a staff person who's getting ready to head upstairs or downstairs somewhere, which will leave this person kind of all alone. And when people are by themselves and don't have a way to get assistance from the staff, that's really a time when a person could have a fall. So those are some accident hazards that are pretty common in long-term care facilities. So then there's the idea of risk. And risk is related to resident characteristics and resident external factors. So the resident characteristics are when you're in the fall literature, we've heard it throughout the different discussions over the course of this series, are these intrinsic factors, things about the resident that makes them more likely to fall. That they have continence issues, that they have lower limb weakness, that they have vision problems, that they have cognition problems. These are things that make it so that aren't really changeable. It's part of the resident and it just puts them at risk. In contrast, there's this idea of external factors, things that are, outside of the resident, but still part of the resident. The kind of footwear they use, the kind of assistive devices that they use, whether or not they're, that you can have bad visions, but you can also not be wearing your glasses. Those kind of external ideas. So what we want to do in this environment is minimize hazards in the environment, minimize risks to the resident, as well as something that's really not included in the CMF's definitions about falls is to enhance the strengths of the residents so that they're using the skill set that they have to maintain very nice upright posture, so not on the floor. So in this slide, I thought we could just take a second to think about some of the resident risks, and I'll just let you look at it for a second or two. It's a little bit blurry, but I think you can tell that this person has had an amputation of some kind, because we have, only one foot hanging down here. And within that foot, it looks like we have some type of brace or something, which put, more of a risk. This dangly shoestring, I'm quite worried about, because if you've only got one foot to balance on, you certainly want to have your footwear to be as sturdy and as possible. We also kind of see some, not a whole lot of upper body strength. So when you're doing transfers, this can certainly be an issue that would be more at risk for falls, as well as kind of this dangly clothing that can get caught. So these are a lot of kind of the more internal risk factors, not the footwear, of course. But then moving through this space, we have a lot of accident hazards, waiting to happen. Yep, we certainly want to have the fire extinguisher in an easy accessible place, but do we want it where people are walking and where they have to take their hands up? And of course, equipment in the hallway, never a good idea. So there's a couple more definitions that are very important when we're talking about long-term care environments and falls. And one of those ideas is the idea of an assistive device or assistance device. It can be called either thing. And that's any item such as fixtures, such as handrails, grab bars, devices or equipment like transfer lifts, canes, wheelchairs, that's used by or that's used in the care of a resident to promote or supplement or enhance resident function and safety. Obviously, long-term care has all kinds of assistive devices, but they need to be safe and kind of in good repair. If you just kind of look at this resident environment for a moment, and we can see kind of a lot of different issues. How much this room is used, hard to say, but this, not the sturdiest commode chair I have ever seen. We have no grab bars in this bathroom, which is an issue. Just trip hazard. Lots of things to run into, bump into, and no place to really grab. So kind of the second piece of this is not only should people have the assistive devices that they need, but they also need to have the supervision necessary to make sure that they aren't getting themselves into accidental trouble. So supervision is an intervention, and it means lessening the risk of an accident. Facilities are obligated to provide adequate supervision to prevent accidents. And adequate supervision is a very broad term. You can't just say, well, we had 5 CNAs on that hallway this afternoon, so that's adequate. It's really defined by the type and the frequency of supervision that's necessary. You need to assess the individual resident needs in an area. Is it adequate to prevent accidents? And you need to make sure that from resident to resident, you have enough supervision, that a person who is, at a high fall risk, is having falls, isn't in a location where getting help is problematic, on a unit where perhaps the staffing is a little bit lower. It's also important to keep in mind that any individual resident may have time fluctuations where their supervision needs are different. This is very common in people who wander a certain time of day, kind of being aware that this is happening and that there is someone who's, attending to this person. Supervision, kind of very fluctuating term. So there's also kind of the idea of kind of safe places, and there are areas within any nursing facility where adequate supervision kind of happens a little bit less often. Resident rooms is definitely one area where people, are often alone and doing things on their own. Like you're getting up to go to the bathroom, they're going over to their wardrobe to pull out an item that they want. So it's hard to keep track of people who are in their individual spaces. Outdoor spaces are also a place where adequate supervision is a little bit of a challenge, because a lot of things can kind of come up when you're outside. So dining rooms at off times, but just kind of making sure that there's not places where people can be without someone there to help out. So we've gone through a whole lot of things, and I'm kind of doing this like the actual guidance goes through things. They talk about a lot of different ideas before they get up to the idea of what is a fall in long-term care facilities. And in this environment, a fall refers to unintentionally coming to rest on the ground or floor or other lower level, but not as a result of an overwhelming external force. So it's not a fall when a resident pushes another resident down. But within a long-term care environment, there's also this idea that is not a fall, is a fall. Because the definition goes on to say that an episode where a resident has lost his or her balance and would have fallen if not for staff intervention, that's a fall. You might consider it a good catch, but we would need to do kind of a workup about falls the same way as we would for someone who landed on the ground. So a fall, when someone doesn't get hurt, that's still a fall. And unless there's evidence to suggest otherwise, when a resident is found on the floor for any reason, unobserved, you have to consider that a fall has occurred, and do your workup in that regard. So that kind of goes through the different aspects of how CMS defines the idea of falls, and what is important to put together for fall prevention. So the idea of accidents, hazards, and risks. Defining between avoidable and unavoidable accidents, identifying hazards in the environment and minimizing those, as well as decreasing the individual risks that people have within themselves. This brings us to the minimum data set, which is, the way that we collect data in long-term care facilities, that we kind of share and make judgments about kind of what's going on in a facility with a resident, as well as kind of across nursing homes in general. So this is a resident assessment and care screening process for common conditions that are often unrecognized or under-evaluated. Section J for health conditions covers the falls assessment, and it basically looks at, on admission, whether someone has fallen 30 days before they got in, if they fell within 6 months prior to their admission, and if they fractured a bone because of a fall in the last 6 months. This kind of puts us at the idea of whether or not we have a faller and whether or not we have a faller who is likely to get injured when people are admitted to the long-term care facility. Then after that, we do follow-up assessments, quarterly. Has the resident fallen since admission? And was there any falls since the last assessment? Let me go back. So we're looking at number of falls, which are categorized as 0, 1, or 2 or more, which is consistent across the fall prevention literature. We're kind of looking at, have you had a fall, at all in the past year? Have you had just 1, or have you had 2 or more? And this revision of the minimum data set looks at falls with no injury, falls with an injury, and falls with a major injury, a fracture of some kind. So, boom. And if anything comes up during the MDS falls assessment in Section J, we're going to have a care trigger, a care area trigger, or a CAT, which used to be the RAPS. Any of these, if any place in the MDS kind of scores positively, care area trigger will be triggered, and then you'll want to put in a fall prevention care plan. So some things like wandering. People are wandering. If there are any balance problems, particularly with transfers or walking or changing kind of from sitting to standing. If any of the codes for the fall history were triggered, if people are on 2 different kinds of medications, anti-anxiety medication or antidepressants, and if anyone's using restraints. These are all kind of high risk areas for future falls in long-term care settings. So the MDS has had some changes in their falls quality indicators between the MDS 2.0 and the MDS 3.0. In the 2.0 version, we're just kind of looking at falls in the past 30 days. This new way of looking at things will be the number of falls since the last assessment period. So that, is 90 days instead of 30 days. So, it's likely that falls will go up as we start using this new system. But what we know about the falls should kind of be better distinctions, because we'll know the number of falls someone has had without any injuries. We'll know how many people have had some type of injury, as well as a major injury like a fracture. So this will really help us be able to kind of compare the whole apples to apples things and the oranges to oranges things, because it's important to know if someone's falling without getting hurt versus falling while getting hurt. So, okay, that kind of comes to the end of Objective 1. Just kind of defining the scope of what falls are in long-term care settings. So, Objective 2 is to describe a model to identify and evaluate fall-related risks and hazards in long-term care settings. So, there's a big challenge in long-term care settings. You have to seek balance between protecting a resident, a single resident, as well as all residents from harm, and supporting the resident's right to make individual choices with maintaining compliance with state and federal regulations. This responsibility to respect a resident's choice, it really kind of may go against at times this facility's obligation to protect a resident from harm, but the facility has the obligation to educate the resident, their family members, and the staff about significant risks related to a resident's choice, and incorporating those choices in a plan of care to reduce the risk of accidents, while honoring what the resident wants. But consent by a resident or the responsible party alone doesn't absolve a facility from assuring for their health and safety. So just because a resident wants something to happen, you have to kind of balance that with making sure that they don't get hurt. And so figuring out a way that their wants can happen, kind of upping maybe their strengths and decreasing risk within that area is kind of the balance challenge. So the regulations, when you're looking at putting together a model for preventing falls in long-term cares, have this assumption, where that all long-term care settings are alike in some way. There are people who need nursing care in them, and very vague terms, accidents, hazard risks, without a whole lot of specification. So we get this kind of picture that it's, a nursing home is this facility with the long hallways, kind of all looking alike. But in nursing home reality, residents are all quite different. You'll have folks that are engaging with their environments, like this person, this is by a window and looking out in the outside world, but also petting an animal. You've got folks who are spending, time alone, kind of going up and down the halls. You've got older people who have dementia or depression and who are spending a lot of time kind of alone. Where you've got people who love to hang out in the different groups and, could be bumping around that way. You've got folks who are there for rehabilitation, and maybe some people who are there for a long stay who are, kind of the Wii junkies now, now that video games are more and more in nursing homes. So everyone's quite different and brings their own risks there. So when we're thinking about, well, how are we going to kind of implement the recommendations, fall prevention strategies in long-term care settings, you have to kind of think of what the intent of the regulation requirement is. And that's to ensure that the long-term care facility provides, an environment that's free from accident hazards, and those over which the facility has control particularly, as well as supervision and assistive devices to each resident to prevent avoidable accidents. So when CMS kind of puts together how people should be taking care of, the process that should be followed in long-term care, you need to identify hazards and risks, evaluate and analyze those hazards and risks, implement interventions to reduce those hazards or risk, and then monitor and modify. Monitor the effectiveness of the interventions and then modify them when necessary. And kind of how this model is outlined in the various guidances that we have from the regulators. It's this kind of linear process where kind of identify. You might modify, kind of back at the intervention stage, but it doesn't necessarily have you going back to the beginning and figuring things out. But a strength of this model that CMS proposes through their guidance is this idea of having a facility that is committed to fall safety, or I like to think of it as a fall safe environment. So you will acknowledge there's a high-risk population and a setting, developing a reporting system, involving staff, directing resources towards safety concerns, and demonstrating commitment to safety at all levels of the organization. So this is kind of my idea of, commitment to fall safety through acknowledging the high-risk population and setting. I think of it as there's so many residents and so many fall hazards and risks. So when you think about any long-term care facility, the people involved need to really know who the residents are and what types of situations they might be bringing in as fall risks. For instance, is there a dementia unit in the facility? People with cognitive impairments, have fluctuating judgments, and, may need more the help of moving people from here or there, keeping them safe, helping them make decisions, versus if there's a skilled unit, a skilled unit where someone, is in for rehabilitation primarily, have had some type of hip replacement or something, and are kind of just building up their strength before they go home. These are people who can really weigh in perhaps on, what their care preferences are and what they want to do and how much exercise they want to do and how they want to do that. So that's a whole different kind of group. A lot of nursing homes have people with developmental disabilities that means you need to tailor to the intellectual level that these folks have so that their lives are rich in activities, but that are safe for them. You might have someone who comes in for hospice care or respite care. Just because a person is engaged in the process of passing on doesn't mean that they won't be up, moving around, and possibly having a fall here and there. And that would be kind of like just a terrible experience for the person and the family to go through. With respite care, someone might be in for a very short period of time while their family's out of town, and you don't know this person very well. So, and then you've got folks who are there, because of psychiatric problems. Again, perhaps some judgment issues. High-tech care, who, may be having intravenous medication given, or maybe on a ventilator, or maybe having some type of wound treatment. All of these kind of places where things that used to happen in the hospital now happen in long-term care facilities. And then you just have people who live there. They've had some type of illness or injury, and they're going to be living there for the rest of their lives. And they're just kind of, that's their everyday life, their everyday home. They're not going to be going anywhere. And, they have a special needs too. So that's kind of, acknowledging these different high-risk populations, bringing in staff who have expertise in those different areas to develop population-specific fall prevention programs is a place, I think, where we need to go next for fall prevention in long-term care facilities. So kind of the second idea for commitment to fall safety is to have the post-fall reporting and monitoring system so that when a fall happens, we are actually kind of following up on that and doing it in a systematic way so that we have information on which to base changes. So when a fall is observed or reported, you find that person on the fall, that it triggers, first off, if the person's injured, that you're providing treatment or referral immediately, then going in, documenting the circumstances of the fall with a standardized tool that's kind of used across the board. A lot of times we do that in long-term care settings, and then it kind of gets put in that resident chart, and it doesn't necessarily get logged into this facility-wide reporting system. We've got a really hassled MDS nurse who's going back at the end, or someone who's on a QI nurse digging through charts, kind of looking at all of these. Whereas if you just log things into a facility-wide reporting system, you could start, identifying trends, patterns into falls. Having a QI or a care team who determines the cause of and contributing factors for an individual fall and implementing the resident care plan for fall prevention, but then kind of looking across the board to evaluate facility fall prevention practices. Are we having falls in a certain area of the building? They all seem to be happening over in the lounge on the West Hall. Well, why is that? What time of day is that happening? What do we need to do differently at this time of day so that these things don't happen anymore? This group getting together to revise facility practices of indicating and then monitoring overall how those changes impact resident and facility fall patterns. The next stage is kind of involving all staff in finding solutions for safe resident environments. And when I was doing my research, which was actually on continence care, I went to a couple different fall assessment, the quality team that was looking at falls at a couple different facilities. And I was quite surprised that there were not residents or family members on those fall prevention teams. And one of the things that staff at each of the facilities told me was that there was this, that they'd be talking about individual residents. And so this would, kind of violate the people's privacy. But I would argue that there is time in which to have conversations about individual residents where staff may be sharing private details. But then there's also times to kind of look at what's happening facility-wide, in which case having residents and family members as part of that fall prevention team, I think, is critical. People who live in long-term care settings experience it much differently than people who just visit long-term care facilities or work in long-term care facilities. So having that perspective is very, very important. Through understanding how residents experience the long-term care environment, then you can bring in, for most multidisciplinary fall prevention interventions, you might have a doctor, a pharmacist, a physical therapist, a nurse, possibly the social worker who would be doing maybe a home care type of intervention. But when you're in long-term care, you have a lot more people to bring in. You have administrators who are going to help decide how resources are going to be used. You'll have the environmental services group. There's a lot of places where people can trip, slip, tumble, fall. Well, you've got people looking at those in dialogue with residents. They'll tell you where their toes are stubbing against something and something, a door frame needs to be changed or something. So having environmental services on this team, dietary, there's some evidence that, it's not to the level where we would say that, it's definitely significant, but, vitamin D might be important. Well, how can dietary help with that? Not to mention, the dietary workers are watching how things happen in the dining room, a place where a lot of falls happen. Bringing in the activities department. Not everything has to happen in the therapy area. You can also do a lot of exercise with activities, and having them be part of the team, very important. As well as pastoral care. When you obtain a fall history from older people in particular, but really people of any age. And if you ask them to describe a fall that they've had in the past, almost everyone has a very readily accessible fall that has a kind of life lesson, something that hasn't been kind of fully explored. And one of the things that older adults are doing towards the end of their lives is figuring out these kind of missed opportunities, places where they've stumbled. So bringing pastoral care in so that they can reflect on the importance of a fall or what was happening or what it means to them, meaning in their life. As well as we have the surveyors, often kind of seen as the antagonist to the situation, but they have really good recommendations on how a facility can improve the care it's giving. So bringing them in onto the team as well is important. So I like to think, instead of kind of that linear model, kind of 4 steps that CMS proposed, that we think of fall prevention process as an adaptive process, where we have kind of 5 steps. Identifying what the issue is, what the risk factors are, what the hazards are, and evaluating them in a systematic way so that we can implement the best interventions as possible. Monitoring them again in a systematic fashion, using something like the nursing outcomes classification, or something beyond what is just in the MDS, to kind of monitor how people are doing in fall prevention over time, and separating that from the idea of modifying those interventions. Because in modifying things, we may need to start the whole process over. It may not be just going back to implementation. And that there's a conversation between each of these steps and across ways. So kind of the rest of this model is going to be based on this idea, which we had kind of way back, the intent of the regulation requirement, ensuring that the long-term care facility provides an environment that's free from accident hazards over which the facility has control, as well as supervision and assistive devices to each resident to prevent avoidable accidents. So this model, I'm going to use the idea of quality indicators for falls, which are kind of generally accepted in the gerontological literature, and suggesting that we look at that. What do we do for each resident? We take the individual perspective, resident focused, focusing on risk reduction, and that we use those same QIs to make changes to the long-term care environment, in which we use a systems perspective. We have a population focus, different populations in this setting, and the idea is looking at hazard prevention. So the third objective for my talk today is to illustrate action steps to reduce fall risk among various resident populations in long-term care. And I'm not sure if you'll be able to see the little cartoon that I've used here, but so this is a very specific individual risk, Fred Astaire, in the later years. So again, as I said, quality indicators for falls, which are commonly accepted in the literature. There are 12 that have some pretty good evidence of their utility. We've figured them out through largely multidisciplinary interventions, multifactorial interventions for vulnerable elders, primarily community dwelling elders. We haven't looked as much in older adults who live in nursing home settings, but I think a lot of the advice is transferable. And so today I'm going to talk about several of them. I'm not going to talk about assessing cognition or assessing and modifying home hazards or the use of assistive devices as needed as correctly. There's been a couple recent and or upcoming sessions that looked at assistive devices. That was a really great one. And I think that there's one on kind of modifying the home setting. So I'll encourage you to look at those more in-depth discussions, because it's more than what I could do today. But we'll talk about a bunch of them. So let's get going. So kind of quality indicator number one. The most important things for improving fall risks, for preventing falls, is to ask people about recent falls. And for each resident, you ask about their fall history at the admission and per the MDS schedule. We kind of talked about that earlier. Once you've identified those folks who are kind of mid-risk fallers, so people who have had a fall recently, within 30 days or 6 months of admission, kind of those mid-risk fallers, and people who didn't get injured, you may want to assess them for falls more recently, maybe as often as each week, to kind of see how things are going. And not only falls, but kind of those trips and slips. Anytime, training the nursing assistants that they bring information about, well, when I was transferring so-and-so, they had some stumbles, I had to catch them, that these things are recognized as falls and kind of assessed and documented and further evaluated more frequently. And then you're going to have some folks who are high-risk fallers. These are people who had injuries in the past 90 days, as well as people who are going through big changes. And for high-risk residents, you might ask them about falls or assess them for falls each shift. For someone who is newly admitted to the facility, doesn't know how to move through that environment, perhaps people who have had a med change, which I'll talk about a little bit later, as well as people who are having delirium or dementia as well. These are high-risk fallers, and you may need to check in with them on each shift to see how things are going. So that's at the resident level. When you're talking about asking about recent falls at the level of the organization, kind of each shift, documenting falls on the standardized form and adding that fall to a facility-wide quality improvement instrument, so that you kind of always have the picture of where are we at regarding falls here, now, today. Each week, that, kind of a quality improvement team, maybe with a nurse and a therapist, reviews the falls log for individual patterns to try to understand what's happening with people and what needs to be kind of changed immediately. And then each month getting together the quality improvement falls team, reviewing those logs for facility-wide patterns and trends, and looking at particularly locations, times, and circumstances. Like Lester's fairly recent article kind of looked at time-related patterns in one skilled nursing facility over 6 months. And while it was a retrospective chart review, so you're not getting, the best details, because whatever people didn't chart, you can't get at, found that the evening shift resulted in more serious injuries than falls that happen on the day shift, and that the kind of highest percentage of falls was from that 4 o'clock to 8 p.m. time. People getting tired, a lot of things have to happen during that time, and not as many staff during the day shift. But figuring out, where are falls happening in your facility? Are people having more outside falls, inside falls? Those are different interventions that need to be put together. Times a day, circumstances. So asking about falls at the facility-wide level. So then, kind of the second quality indicator across different groups is that you would do a basic falls assessment. For people who are just first admitted or in the quarterly, you're observing gait and balance. Just have them kind of walk, do a short little timed up and go test, see how things are going. Monitor physical function changes along the way, so that nursing and therapy is really working with nursing assistants who know first when physical function changes are happening. It's harder to get the shoe on someone because they're kind of stiffening up. We're having a hard time with the transfers. I'm having to wheel them down the hall instead of walking down like we did a few weeks ago. So in people who've had a single fall in the past 6 months and no injury, physical therapy might conduct, kind of a more in-depth gait and balance evaluation, looking for balance, looking for endurance, looking for strength, and recommend, making recommendations from there. For folks who have 2 or more falls or a fall with injury, that a full multidisciplinary fall and risk factor evaluation is implemented to figure out what's happening here and how we can improve this person's risk factors as well as their quality of life. So that's at the resident level. Again, when you're looking at this, basic fall evaluation from a perspective of the facility, that you're looking kind of, again, each shift. It may seem like overkill, but it's better than, having a bunch of falls. So kind of the idea of doing a fall sweep. The staff and even the residents could scan the facility or the environmental, for environmental hazards. I kind of think of this as how when I'm asking a kid to pick up, find 3 things in here that don't belong where they're at, and you can find a lot of things that, those wheelchairs that were out in the hallway or magazines that were left on the floor, whatever. But documenting those hazards in kind of the fall log so that the quality improvement team can identify patterns that are happening shift to shift across time. I think that's a useful intervention, as well as facility-wide, each unit, that staff is trained to cover the hazards that are common to the unit or to the hall, as well as the fall risks in each resident. The people that they are, this kind of assumes that there's more of a kind of a primary care relationship between the nurses and nursing assistants and residents, which is probably most helpful for reducing fall risk. But reasons why people would fall in the dementia unit are different than why people might fall in the in the skilled unit, and making sure that people understand those differences and are alerted to what to how they need to behave to minimize those risks. And then facility-wide, reviewing the fall-related procedures. Are they up to date? Are you doing things that are not standards of care or best practices? Reviewing equipment instructions, not only within just a unit, but that everybody is kind of up to date on how equipment should be used, because we kind of forget over time and we start using it the easy way instead of the right way. And then kind of also looking at fall hazards on a seasonal basis, because things change. Why people fall in summer is different than why people fall in winter, and not only reviewing those kind of so that people are alerted to them, but putting different interventions into place different times of the year. So, quality indicator 3, detecting orthostatic blood pressure problems. Within each resident, checking the orthostatic blood pressure and pulse at admission, and quarterly in PRN, so that you know where people are at. When you move into a new settings, what you eat change, what meds you take change, everything kind of changes, and so catching orthostatic blood pressure issues early so that you can intervene if necessary. So someone who's a recent faller, you should document the orthostatic, vital signs. Maybe not right after the falls, but that week, and kind of continuing it to look over the month so that you can identify if there's a pattern. And then when someone who has an orthostatic blood pressure problem is identified, that that they're doing a syncope evaluation by their primary care provider, correcting the underlying causes of the problem, and that the long-term care staff are instituting fall precautions, so that someone isn't popping down up from a laying position and being stood up and walked across the room, but are given a chance to kind of let their blood pressure settle in and settle up. So then looking at orthostatic blood pressure problems at the facility level, one of the big things is just making sure that you have a protocol in place for how to measure orthostatic blood pressures. We and his colleagues did a prospective study in which they looked at how often people fell related to their blood pressure problems, and there was people with a history of previous falls. Those with orthostatic hypertension were 2 times more likely to fall. So that kind of gets you why. But then looking at kind of the protocol and staff skills testing, Lillian and her colleagues, Lillian Vlot, actually did a study where they evaluated the skills and knowledge of orthostatic blood pressure measurements for elderly patients. They were in 8 different elder care hospitals in the Netherlands, and observed 10 nurses at 17 different wards, and figured out that oftentimes nurses used the wrong equipment, or they used it in the wrong way. The documentation was not, often was not, time was often not documented, so you couldn't tell how long apart it was between the lying and the standing blood pressure. In 28% of the cases, the arm was not positioned, for example, at heart level during the standing blood pressure measurements. 46% of the time, either the wrong cuff was used or the cuff was placed incorrectly. So if you're going to, institute kind of orthostatic blood pressure monitoring, it's really important to get the staff skills up to date, to certified nurses and nursing assistants on the measurement of this skill at hire and then annually after that. So kind of quality indicator number 4, assessing vision problems. So vision should be kind of screened and, at admission. Has someone had a recent eye exam annually thereafter that? Also, you can document vision, kind of the health-related quality of life using an instrument like that. to figure out, if people's vision is changing how they enjoy their lives. For people who have a vision problem, beyond the need of just the corrective lenses, referring them for further evaluation, and just for anyone who has a vision problem, that they're using their glasses and that their glasses are clean, and that the eye medications are delivered as prescribed. So then looking at assessing vision problems at the facility level. So there's the visual environment, largely related to light. And there's a study, La Polaire, possibly, I'm not exactly sure how to say the name. They're a team from Belgium who looked at the adequacy of the light levels in nursing homes to see if it kind of met the visual needs of elderly residents. And they looked at, they measured it with a light meter at 4 times a day. Well, 4 different kinds of days, actually. Sunny day, a cloudy day, when dusk was falling, and when it was dark. And at each of those times, the amount of light was measured in 16 different places that were used by residents. And pretty much across the board, there was not enough light for older adults to kind of see what was going on. There was no nursing home that met the kind of adapted standards in at least 8 of 16 of those places during those different times of the day. So making sure that the light you have is neither too bright nor too dim for older adults. Then just enhancing vision enhancing interventions, that people are trained on using those corrective lenses, and how to kind of look through the visual environment to see, is the light in here enough? Is it, what these people need? And Dr. Teresi has done a study that looked at vision interventions to improve functional status in nursing home residents. And, they found that just kind of doing these reinforcing techniques with the staff really improved how much people were getting what they needed to be able to see properly. A quality indicator, kind of 5 and 6 go together, screening for balance and for gait problems. So for each resident, that you're conducting a brief assessment, again, standardized across everyone, whether it is a timed up and go or some other type of assessment that combines the idea of getting up, balancing, walking through time. And then once you've identified a gait or balance problem in a person, that, physical therapy, occupational therapy is working with nursing and the activities department to develop a program for gait and balance training, and that you practice gait and balance in everyday settings. There's going to the gym and practicing, with the physical therapist, but then, most of the time people are going to be walking through their room. They're going to be walking through the hallway. They're going to be walking, past someone in the dining room, and kind of getting it so that practicing standing tall and standing strong in their everyday setting is very, very important. At the facility level, these gait and balance tasks don't have to be boring. One thing you could do is kind of conduct a facility-wide balance and gait Olympics, kind of screening people during exercise class. I'm not proposing that we race people up and down the hall, but, it's kind of fun to see how you do against the timer, and, at the end you get a prize. You can also introduce balance training through video game technology to make some of those exercises that they do in activity class a little more fun, a little more competitive. That's how you can kind of bring it to the facility level, as well as screening for common balance problems and gaits in special populations within your facility. What's happening in the dementia unit, what's happening in the skilled unit, as well as kind of folks who are on new medications or high-risk meds. looking at gait and balance, from that perspective. So another quality indicator is reviewing, discontinuing high-risk meds. Not everyone's going to be able to get off a med, but there's been a recent study where, well, let me go this way first. So each resident having a medication review at admission quarterly, PRN, if you've been to the hospital, if they've been to the doctor or their nurse practitioner and have gotten a new medication order, that this is being reviewed, looking for interactions, looking for possible risk to falls. For folks who are high-risk med users, identifying them and sharing that information across the care team, especially when new meds or dose changes are happening, that you may initiate fall precautions. So certain antidepressants, especially the non-SSRI ones, the selective serotonin reuptake inhibitors. So if you're taking one that's not an SSRI, nursing home residents are at a significantly greater risk for falls. And those falls happen kind of over time. For the first 2 days after there's a change in these antidepressants, people are much more likely to fall, like 5 times more likely to fall. That's a big risk. So that there would be kind of a med alert given kind of across the board, so that people know that so-and-so had an increase in this med, or they've changed their dose, or they started this dose, and that there's increased supervision for that first week after the med change until you figure out how people are going to respond to that. And kind of the last quality indicator that I'm going to talk about is exercise. I don't think that there is any evidence that exercise is bad for a person. And so for each resident, encouraging exercise, exercising in everyday situations, that you do a couple heel lifts when you're getting out of bed, that you do a deep knee bend here or there, as you're moving around, so that that the exercise is happening within the context of a life, and that people are standing up, people are walking. There's a lot of sitting that happens, and the more people sit, the more likely they are actually to die. So, get up, stand up, whatever. So, and then within the high risk fallers, that exercise is not just general exercise, but it is to improve gait, balance, strength, or endurance. That these are structured, supervised exercise programs targeted to specific fall risks. So, and engaging folks. We still have nursing homes that look like this, where people are kind of lined up in their chair and not moving around. Or maybe we've got the exercise class where people are sitting. And if we can get to the place where people are standing up, moving around, maybe even going outside and taking the fresh air along with their exercise, the more engagement, the better. So we're down to kind of the end. And this is objective 4, and it's going to be kind of short and sweet because it's something I want. We don't have much literature about strategies to foster positive staff attitudes towards a fall-safe environment. But we do know this from Deaver and Fitzgerald, that caregivers can develop kind of a fear avoidance model of falls. And so when folks, nurses, nursing assistants, fear falling among people, this study was done with people who worked with persons with dementia in long-term care, controlling for the baseline functional status of the older adult, controlling for their physical risk factors. If their caregivers reported that they were worried or feared the person falling, that was predictive of restraint use or restriction use at 3 months. And that restraint use was predictive of functional ability decline and injurious falls. So when you've got caregivers who are worried about older adults falling, they're likely to overprotect them in a way that will actually make it more likely that the older adult will fall and have an injurious fall. So this is kind of, this is my blank screen. The extemporaneous part I talked about earlier on. And I think empowering staff to make changes. Changes don't have to cost a lot of money. Changes should be based on what residents want. And I think a great way to kind of help staff understand what it is that they are or aren't doing to help residents maintain a fall-safe environment is to send the residents off with a camera and to kind of do a photo voice intervention where residents take pictures of places or situations where they have fallen, worry about falling, want to prevent themselves from ever falling, and having the residents kind of talk about that with staff. Here's what things are going on. You know, are you aware of this? And the resident and staff working together to figure out ways to kind of improve the care and fall prevention strategies in this setting. I think kind of the best way to do this is mostly through dialogue. And dialogue has the word log in it. So, you know, making sure that we're kind of looking, documenting, seeing these things over time, going back and changing things that aren't working. So that's what I have today to talk to you about for falls in long-term care settings. I hope that was useful to you. I have some references here. I have some references kind of scattered throughout as well. I had a delightful time talking with you today. I hope it helped a little bit, and kind of go out there, talk to residents, figure out what they want to kind of improve the fall safe environments in their facilities. So thanks a lot.